Hi, what a great meeting, and thank you, Alex, again, and all of the organizers for having me. So we're going to switch gears. It's actually perfect seg from Joe's talk about glaucoma as a brain disease. But before I get started, does anybody recognize her? She's 50. I'll give you hints. Location, Germany. So this patient presented to a physician with some confusion, gradual changes, and memory loss. And a few years later, she died, and the physician caring for her looked under the microscope and saw this. So this is a classic plaque of Alzheimer's disease with a neurofibrillary tangle, and that physician was Alois Alzheimer. To this day, this is the pathognomonic method to diagnose Alzheimer under the microscope. And when we think about Alzheimer's, we have 27 million people around the world. They're mainly 60 or older. It affects the cognitive neurons, and it's a progressive decline. When you think about glaucoma, we're close to 80 million people, mainly 60 and older, a loss of vision neurons, and a progressive visual decline. And I hope that by the time I'm finished with this short talk, that when you look at an optic nerve in the clinics tomorrow, that you'll think about the disease just a little bit differently. And I'm going to ask you to come on a little journey with me about how, and some of the work that tried to look at what is happening behind the level of the optic nerve. And so the first study that I'm going to share with you is, let's go one step past Joe's study of the lamina, and let's hit right behind the eye. And let's take a group of monkeys, and this is a study in which a group of monkeys had laser scarification to the trabecular meshwork, and their pressures were raised, and so that's the top bar, and versus a control group. And then we cut behind the globe, and these are the optic nerves stained with myelin. And you can see on the far right, you've got a big fat nerve full of about 1 million nerve fibers. And based on the glaucoma severity, on the left, you've got different degrees of damage, with the top left really quite shot. Probably not much left there. And this is work of Yeni Yücel in San Diego. When we look at the nerve at that level, even at the electron microscopy level, very difficult to know what those neurons, what kinds they are. Are they magno, parvo, conio? But the beauty is that when we're trying to understand the damage, we should remember that the retinal ganglion cell body is located in the eye, but actually most of the retinal ganglion cell lies outside of the eye. And if you follow it along, that axon actually terminates in the lateral geniculate nucleus. So when we're treating the eye, it's actually a very small portion of the retinal ganglion cell that we're getting. So let's take it to the lateral geniculate nucleus. Beautifully, exquisitely organized 6 layers, where you have the motion neurons in the 2 ventral layers. You have the red-green, the 4 dorsal, and sandwiched in between each one of those layers, we have the coniocellular. And if you were to think about SWAP, that picks up the blue-yellow, that's where they're located, in between the layers. So let's go back to the monkeys. If we take those monkeys and we raise the pressure, and then we slice through the lateral geniculate nucleus, and we just have a look, what we see is that the monkeys on glaucoma look like they have a bit of a shrunken lateral geniculate nucleus compared to control. And so in a series of studies, the first thing was, well, let's look at them under the microscope and let's stain them with something that's very specific. And you can see on the left, you've got control, you've got these nice juicy brown neurons that look like they're numerous compared to the control side where they're sparse and smaller. But in science, we're not allowed to get away with just sort of a look like that, and we actually have to measure them. And so when we measured these neurons under the microscope, we actually counted them and found that in both the magno and the parvo, the glaucoma in yellow showed a significant reduction in the number of neurons that were actually still there. And so we could see here that in glaucoma, at least in the monkey model of glaucoma, when you count out the neurons actually die in the lateral geniculate nucleus. So we were, of course, very curious to find out, well, what happens to the ones that are left behind? And so to do that, we measured their size, and there was an overall shift to the left in the remaining. This is a frequency distribution where you have the radius of the neurons on the bottom and the percent frequency on the y-axis. And you can see there's a shift to the left at all different sizes compared to controls, the green. And through further study, it was found that actually the lateral geniculate nucleus neurons shrink in glaucoma. And so this is published way back in 2001. We're very curious to find out about that third pathway, the coniocellular neurons, and it turns out that coniocellular neurons can actually be identified with a protein marker, CAMK2 alpha. And you can see that the CAMK2 alpha on the right got a few neurons sandwiched between, but when we actually looked in the glaucoma brains, the immunoreactivity for these was significantly lower in the glaucoma. And so based on these sort of series of studies, we were able to at least be assured that in glaucoma monkey, if you raise the pressure in one eye and you look at the brain, the lateral geniculate nucleus, the major target, that we actually have all three pathways affected. And so, and this is an article that puts all of that work together. So, considering that the lateral geniculate nucleus is affected, we wouldn't be too surprised then, knowing that most of the retinal ganglion cells project to the lateral geniculate nucleus, then we might actually expect to see changes back in the visual cortex, since that would be the next place that they're heading. And looking at metabolic activity in the visual cortex in these monkeys, we use cytochrome oxidase, which looks at, and in the normal, if you stain the visual cortex with cytochrome oxidase, you just get even distribution of staining. But on the bottom, you can see that in glaucoma, you've got these alternating light and dark bands that actually correspond to the ocular dominance columns driven by the glaucoma and the non-glaucoma eyes. And so, to summarize here, in primate glaucoma, neurons shrink, they die, all three pathways appear to be affected, and we can see changes at the level of the visual cortex in primate glaucoma. So naturally, very interested to know what's happening in human glaucoma, and is this relevant? And so this is a patient, a 79-year-old gentleman who came to me. He presented with 0.9 cups on a single medical therapy. And these were his feels. About 18 months later, he died, and he had previously consented to be for medical and research purposes for his brain and eyes. And so I'd like to show you in this patient findings at the level of just before the chiasm, so way up before the chiasm, at the level of the lateral geniculate nucleus, and also at the level of the visual cortex. And so the first thing we did is our index case is in the center. So this is a neurofilament stain compared to 4 age-matched controls of the same age. And you can see it's quite shrunken, all the way up pre-chiasmal. When we look at his lateral geniculate nucleus on the right, compared to control, this is the largest cross-sectional area. It appears similar to what we saw in the monkey. It's kind of shrunken. And when we looked at the visual cortex mantle, what we can see in glaucoma is that there is a shrinkage of the mantle. And so just fast forward, now we're at 2006. So at this time, we basically were assured that, you know what, in human glaucoma, when we've got these advanced changes, we're probably going to be seeing degenerative changes in major vision centers of the brain. And so that's that publication. And so we thought, well, that's in patients. It was post-mortem. What about our patients in the clinic? And so using a 1.5 Tesla MRI that's available in any hospital, we said, let's go out and let's see if we can image with an MRI the lateral geniculate nucleus. Well, how are we going to measure the lateral geniculate nucleus? So, you know, in Alzheimer's disease, they measure the height of the hippocampus. So we said, well, let's do the same thing. Let's get a bunch of neuroradiologists, blind them to the diagnosis, and we'll get them to help us image the lateral geniculate nucleus and come up with the vertical height. And we looked at a group of patients, and all of them we were able to image the lateral geniculate nucleus. And what we found was that there was atrophy of the lateral geniculate nucleus that was detected by MRI. And this is now in 2009. So at this time, this is quite early. This was the first structural evidence of changes in human glaucoma. But at this point, there was a revolution that everybody wanted to see the brain in glaucoma, whether it's microstructure, perfusion, activity, connectivity, or metabolism. And it's impossible to give you a root, but if you were to do a literature search now, you would see that there has been an exponential increase in interest in the area, and centers around the world in every country have, and this is just one from Japan, where unique degenerative changes in the monkey. This is diffusion tensor analysis that looks at glaucoma in the white matter tracts. This is another one that is looking further back in the nerve, a group from Italy, Carlo Nucci. This is out of China, where they're looking at higher resolution 3T MRI Tesla. So, and all of the findings are pointing to these changes in glaucoma, and including the visual cortex, and many more that can't be included. But just to summarize, without that non-extensively, the lateral geniculate nucleus has changes when you image it. The white matter tract optic radiations have changes. The visual cortex and beyond have changes. So it's no wonder patients have problems seeing, because you have contacts destroyed, you have signal processing disturbed, and you have loss of vision. And so far, what we've described is the retinal geniculo-cortical pathway. But there's another pathway that we must not forget about, and that is the pathway that includes the superior colliculus. And the reason that this is so important is because the superior colliculus is important for our eye movements, our rapid eye movements, our ability to scan the environment quickly, look into a grocery store, make sure you're not falling down the stairs. And so we conducted a study, and again, this is a journey, and some of the work and some of the thinking behind it. We thought, well, all of these structures are being, I'm wondering whether the movement pathways are also affected. And so we actually had now he's a glaucoma specialist, but at the time he was trying to get into ophthalmology, sent him to the UK, where he trained and picked up these, brought it back. This is a head-mounted device where you can use saccadic eye movements. And we were actually able to show, Regine actually showed that the saccadic eye movements are delayed in glaucoma. And there's a tremendous amount of work coming out of Moorfields and David Crabb and a lot with Ted's group that all of these things, that there's much more other than our static white on white field. And if we were to actually go out and seek changes, that we would find that there are a lot of things that we could pick up, and that, you know, there's got to be some better ways to measure or to understand what the patients are suffering. And so there's a lot that can be done in terms of understanding it. This is just a review of sort of a framework for people interested in looking at this field, how some of the benefits of looking at it in a systematic method. The take-home message is that the glaucoma disease really shows extensive involvement of brain pathways that are responsible for vision. Now, when you think about Alzheimer's, they're way ahead in terms of biomarkers, right? They're looking, they can pick up biomarkers in the CSF. They've got candidate molecules. They've got drugs out that protect it. We don't have any of that for glaucoma, but if we were to look, where should we look? So let's think about it. You've got central visual neurons degenerating. Those byproducts are going to end up in your extracellular spaces and eventually will find themselves in the blood somewhere. And so when we're looking for, searching for these biomarkers of glaucoma, should we be looking in the aqueous? Should we be looking at these, at the lymph? Should we be looking at the vitreous? And what about the cerebrospinal fluid? Before I end, new findings about the CSF and the nerve. You know, we always think of the subarachnoid space around the nerve as sort of being in a separate compartment from the substance of the nerve. But recently, with our PhD student Emily Matthew in the lab, we found that CSF actually enters the optic nerve. And this is recent work that was published last year. And so it's another thing to add to something that we need to understand in terms of CSF, the relationship to optic nerve. And of course, we were very interested in understanding, could this somehow be related to glaucoma disease? And so we looked at studying this particular pathway in glaucoma, and without getting into too much detail, there's the CSF traveling through the subarachnoid space at the top, and that's where it would go through. It lines capillaries lined on one side by astrocytes and the capillaries on the other side. That's where it's coming through. But in glaucoma, we find that actually it's impeded, and this is in press currently, and so it looks like CSF actually entry into the optic nerve is impaired. Now, what does this mean? I don't think we really know. I think it points to the fact that we have to look at fluids more closely and the potential role that they have in glaucoma damage, and that maybe as we're looking at the tissues and the damage, we might want to pay attention to the fluids, the inflow, the outflow, the drainage, the waste product removal that might be involved. And so the visual brain in glaucoma, we know, is affected early. It's a biomarker, possibly a tool. There's lots of opportunities for medicines to slow the disease. It'd be great, while we're protecting the eye, to keep the central visual system robust and protected, and targeting the eye, target the visual pathways, and not to forget, of course, about the patient and any modifiable risk factors that Joe suggested, you know, exercise and some of the other things. So, in closing, tomorrow when you go to the clinics, just remember this is probably just the tip of the iceberg. So thank you very much, and thank you so much. It's been just wonderful to be here.